Good morning or afternoon, everyone. Thank you for joining our March Craig Rehab U webinar series. I'm Tracy Tenson. I'm with Craig Hospital's Provider Relations team, and I'll be your moderator today. As a bit of housekeeping regarding continuing education credits, wanted to let you know that we will have 3 poll questions that'll be launched throughout the webinar. Please be sure to answer all the questions to receive credit. In all honesty, you have to answer 2 of the 3, but we won't mince words there. And you must attend at least 50 minutes of the presentation. Credit will go to those who have signed on using the email that you registered for the presentation. If you're in a room with multiple people, please know that each person needs to sign on individually. If I do have folks in a room together, you can reach out to me separately and I can see if I can get everyone credit, since I know we're at the beginning of this now, but primarily you do need to be signed on individually. Credit is being provided from our partners at CEU Institute. So you'll be receiving an email directly from them after the webinar regarding the credits and any additional information they might need from you. I do have one update about an approval that we did not receive. I'm not sure why, I just found out. So we did not receive credit in North Dakota for speech language pathologists. My apologies, I'm not sure, like I said, why, but if anyone's looking for the North Dakota SLP, we did not get approval. Today's presentation is being given by Craig Hospital's Dr. Bibi Stang, who's one of our amazing brain injury clinical neuropsychologists. Dr. Stang has experience in providing holistic care in collaboration with interdisciplinary teams to both patients and their families. Her work focuses primarily on the neuropsychological evaluation and treatment of patients with acquired brain injury and the support of family members affected by these life-changing events. Dr. Stang obtained her doctorate in clinical psychology from Palo Alto University. She completed her pre-doctoral internship in clinical neuropsychology at the Phoenix Veterans Affairs Medical Healthcare System and her postdoctoral fellowship in clinical neurorehabilitation at Barrow Neurological Institute. If you have any questions during the webinar, please feel free to submit a question in the chat or message windows, and Dr. Stang and I will answer any questions at the end of the presentation if time permits. And without further ado, I will hand things over to Bibi.
Thank you very much, Tracy. So as Tracy mentioned, my name is Bibi Stang. I am one of the clinical neuropsychologists here at Craig Hospital. And today I'm going to be talking a little bit about just the neuropsychological assessment and treatment planning. Our learning objectives for today is, being able to summarize the major areas of cognition that are assessed following an acquired brain injury. Describe the value of neuropsychological assessment in tracking cognitive changes following an acquired brain injury, and then describe the implementation of these assessment results into treatment planning. I do just want to put out there that there are no financial disclosures. Before I kind of go into the meat of my presentation, I kind of want us to hold this in the back of our mind. So the rehabilitation process is analogous to running a marathon or perhaps even a triathlon for the more complex cases, with the caveat that our patients and families do not get to train beforehand. A TBI is not an event, but rather a chronic disease process that often does not have a designated finish line. And patients undergoing rehab do not always achieve a sense of victory, even when apparent progress is evident. I really want to emphasize, that this process in serving those with acquired brain injury is a team effort. And there's a lot of literature and research out there that shows the benefits of approaching these folks with a holistic treatment program, which includes neuropsychology, but also speech therapy, occupational therapy, physical therapy, social work, and so many others, to really look at someone and their families as a whole. And now we'll kind of go into how neuropsychology kind of contributes, and that it's a piece of the whole process. So, what is neuropsychology? It's basically the study of brain behavior relationships. And we're able to provide some evaluations that can be helpful and provide unique information about an individual's cognitive, emotional, and behavior functioning. The types of tests that we use are standardized assessment tools that allow us to integrate the findings and other data to determine what cognitive changes have occurred, kind of help us differentiate between, is this more of a psychiatric condition versus something neurologic? And then kind of think holistically of how is this going to impact someone's daily functioning. All of the standardized tests that we use were created with kind of forming these normative databases. So having a bunch of healthy individuals complete these types of tasks so that when we perform these tests, we can compare our folks with those who are similarly aged. And some of our tests do allow us to factor in ethnicity, education, and sex. As you can see, there's a lot of different ways that we can use the information that we gather from these types of evaluations. And we'll kind of talk about some of these throughout the presentation. And I do want to highlight that, most of the patients and families that kind of go through this process of engaging in a neuropsychological evaluation tend to find it pretty helpful because it starts to help lay the groundwork for an understanding of what's happened. Sometimes it can be even validating in terms of their experience, and it kind of jumpstarts the process of helping those kind of cope with the cognitive, emotional, and behavior changes. I feel incredibly fortunate to be a part of, the culture of Craig here, because neuropsychology and psychology is so heavily integrated into our treatment programs here. I recognize that that is not always the case in every setting. So I kind of wanted to highlight a little bit kind of when it might be helpful to include a neuropsychologist on the inpatient setting as well as in the outpatient setting. So in the inpatient setting, it could be helpful just whenever possible to advocate for a neuropsychological consultation, because in that kind of initial phases where we'll be able to help provide some information about their cognitive functioning, behavior, emotional state in relation to that brain injury. And then we can start laying some of that groundwork of providing that education if the individual's ready, but most importantly to their support system. In the outpatient setting, it might be helpful to include a neuropsychologist if some new information is needed about that individual regarding the brain injury, like they're making changes, you're noticing improvements. It might be helpful just to take an updated look at their thinking. Sometimes it's helpful to note it, if there's a change in functioning, especially if there's a decline. Or if, let's say, you're working with someone and you find out that there is a history of brain injury and they never had the opportunity to have their thinking skills assessed, it might be helpful to seek that neuropsychological evaluation. All right, we'll go ahead and start with that first poll question, please.
And I apologize, I guess my microphone, can you hear me better on this microphone now, Bibi? No? Okay.
It's still a little bit choppy.
Not sure what's going on with that. So my apologies for my audio. I'm just glad you can hear Bibi. I will go ahead and launch this first poll. We'll give it about a minute for everyone to answer. We're at about 92% that have answered, Bibi. So I don't know if you want to go ahead and read it off the answer.
Yep, perfect. So it's basically asking about, can neuropsychology can provide helpful information in a variety of ways, and that is true. As we just discussed before, there's a lot of different information that an evaluation from neuropsychology can offer to the treatment team, to the individual, to their families. All right. So to kind of go into like what exactly goes into, excuse me, an evaluation, it's important to note that, with with these types of evaluations, it's important to be flexible. So they can range from a quick bedside assessment to something that's a lot more lengthy and comprehensive. In general, I mean, it's important to get that clinical interview just to gather as much information as possible. I think getting that collateral information from a family member or someone that knows the individual well is incredibly helpful. It's also an opportunity to kind of just learn and better understand the impact of the brain injury on functioning and how they are compensating for these challenges. Sometimes we get kind of an idea of that even on as soon as inpatient, but you definitely get more of an idea of how that's looking like as an outpatient. I think the key thing that I'm always looking for when I first meet an individual is their level of insight and awareness into their injury and kind of the impact that it's having on their daily functioning. I'm going to get more detail into that, but that is something that I keep a close eye on when I first meet someone and as I continue to work with somebody. It's also an opportunity to gather additional information about other things that might be contributing to, how they're, the impact on their thinking skills and how they're functioning. It's important to ask about, sleep, level of fatigue, their mood, what medications are they on, any substance use, are there recent changes in their support system? Are there any stressors going on? So gather as much information about their history and what they're experiencing. And then you kind of transition into doing the evaluation and then providing some feedback and recommendations. And we will kind of go through these different steps and give you a little bit more information. In deciding kind of how to approach this, I think the most important thing is kind of knowing what's going to be the most helpful and what kind of information is going to be the most helpful for the patient, their family, and also the treatment team. Because sometimes they're looking for specific kinds of answers or information. To kind of help this information kind of come alive, I wanted to share, we're going to go through a case example, Mr. X, throughout this presentation just to kind of help show how some of this is applied. So Mr. X is a 20-year-old male, right-handed, Caucasian. He sustained a TBI secondary to a fall in 2018, and alcohol was involved. A little bit of background information about Mr. X. At the time, he was in college working on a degree in the field of arts and communication. No history of ADHD or learning disabilities. He did have a prior history of engaging in mental health services, most notably during his adolescence. He sought help for symptoms of depression and anxiety. And as I mentioned, he did engage in some mental health services. And interestingly, as he kind of was able to talk a little bit more about some of those experiences, he didn't find them all that helpful. And so that was definitely something that he and I needed to kind of work through. And he also came from an incredibly close-knit family system who he essentially had a really strong supportive family. His initial neuroimaging showed bilateral hemorrhages, mostly impacting both his temporal lobes, left a little greater than right, both his frontal lobes, right a little bit greater than left, and some diffuse axonal injury. When he initially arrived to our inpatient setting, he was approximately 1 month post-injury. He was still in PTA. His expressive language was confused and did not fit the context of the situation. So what we kind of learned with the help of his speech therapist was actually his head, just the nonverbal gestures. So using his head to say yes or no was a lot more accurate in answering yes, no types of questions. He tended to perseverate on different ideas throughout the day. His mood was very labile and quick to change, especially when he was fatigued or overstimulated. And headaches were also a big barrier, or a big prominent issue for him. There's a lot of flexibility that needs to happen here because he was still in PTA. I needed to build some rapport with him. I didn't complete that initial neuropsych testing until approximately 9 weeks post his brain injury, and we'll get into that a little bit more a little bit later here. So what are some of the cognitive domains that we can look at? I think most importantly, it's important to establish kind of some premorbid estimates. Where was this individual functioning in terms of their thinking skills before the injury? And we can use a combination of standardized measures, taking into consideration educational history and vocational history. And it kind of gives us a sense of, okay, not that I'm anticipating all cognitive abilities to fall, within that, kind of premorbid estimate. We all have natural strengths. We all have areas that are a little bit weaker. But at least gives us an idea of what are we aiming for? So most recently, I estimated someone's premorbid functioning to be in the high average to superior range. And so that just kind of gives the team an idea of where the bar is at. What are we aiming for in terms of someone's level of functioning before this injury? And so with this particular individual who's higher premorbidly functioning, an average score might actually be a self-relative weakness for him, even though it's falling within normal limits. So it's important to kind of have that in the back of your mind. Another area is attention. Attention and processing speed are both really important functions when you think about thinking skills that kind of lead to some of the more complex ones, which we'll talk about in a moment here. And attention can be divided into a couple different sections. By no means are these the end all be all. There's definitely a lot of ways to look at attention. There's basic attention, so like being able to rattle off a phone number. There's selective attention or focused attention, and that's basically the ability to focus on something and tune everything else out. So for an example would be being able to attend to a conversation with a friend at a busy restaurant. And then there's also divided attention, which is a lot more complex. And it's basically the ability to process more than one piece of information at a time and kind of alternating between those two. And so an example of that could be, let's say, at that busy restaurant, while you're having a conversation with your friend, you're also kind of calculating the tip that you're going to put on the bill. Another example would be, being able to drive, attending, to your speed, to what's happening around you, and also maybe listening to the conversation that you're having with your passenger all simultaneously. And then, like I mentioned, processing speed, just that's the ability to process information efficiently, whether that's visual, auditory, sensory, and we can assess that with or without a motor component, so handwritten sort of stuff. All right. Another domain that we look at or can assess is memory. Memory is kind of this process of integrating, taking in verbal information, visual information, encoding it, storing it, and then being able to retrieve it at a later date. And an injury or resulting memory deficits can impact any of these steps along the way in terms of how memory is stored. And again, I wanted to highlight that attention and processing speed is an important part to that. And so if there are changes there, it can clearly and obviously have an impact on our memory. We can look at memory, verbal memory, visual memory. We can even look at, does structure help, or like a story, does that help someone's memory? Or in a way that, or on structure, can you kind of put in that structure in on yourself? And let's see. In terms of visuospatial and visio-constructional abilities, this may not always be evident to the patient or family members. Sometimes it's, we notice it on the inpatient side where someone's not attending to the left side, or we start exploring and seeing that there's some visual field cuts that can kind of impact someone's functioning and how they're attending or paying attention to their environment. In terms of language abilities, we have different tests that can look at someone's ability to understand language as well as express. This is definitely an area where I lean heavily on my speech therapy counterparts to kind of tease out exactly what's happening, and it's a fun, neat collaborative process to figure that out together. One thing that can happen with language is after an injury, sometimes people can see a change in their ability to understand someone's tone, and this kind of goes under the visuospatial abilities, kind of being able to see and understand facial expressions, which of course can really have a big impact on how they're interacting with others. And something that neuropsychology can add is kind of looking and exploring into how those have changed as a result of an injury. All right. Another area that we can explore with our evaluations are executive functioning. So that's really kind of our ability to think flexibly, problem solve, kind of our self-reflection, judgment, kind of these higher level thinking skills. I fully recognize that, you know, when we do these types of evaluations, we're in a quiet environment that's, you know, relatively distraction free. And so we're kind of gathering this information, you know, at someone's function at their best, you know, because then we're in a quiet environment, and that it may not necessarily reflect exactly what they're experiencing in the kind of real world where there's a lot of different things happening. So it's important to incorporate, you know, that collateral information that you get from family, but also just your observations. And I recognize on an inpatient side, I've got the luxury of being able to incorporate that, as well as the feedback that I'm getting from my team members about how someone's functioning from an executive, or with their executive functioning. Let's see. Another thing that we tend to assess is just mood, depression, anxiety. We can also incorporate some personality measures, just to kind of get a sense of, can that kind of help us better understand what's happening and how someone is presenting, especially when there are maladaptive behaviors that are, let's say, getting in the way of therapeutic processes. Let's see. I do want to mention that, you know, when it comes to what's stressful on family members or their support network, is really those, when executive functioning is impacted, when there's, you know, significant mood or behavior concerns, as well as if the individual's level of insight or awareness is impaired, that tends to increase family or the support network's kind of stress. And it's important to kind of be able to have that kind of conversation with them, and neuropsychology can definitely help navigate and provide that kind of education. All right, Tracy, we are ready for poll question number 2, please.
Great. I will go ahead and get that launched.
Thank you.
And would you mind reading the question out, since my audio is, I guess, a little wonky?
Oh, yeah, sure. I'm sorry. So executive functioning encompasses which of the following cognitive abilities: emotion regulation, initiation, flexible thinking, or all of the above?
Thanks. We'll give about another 30 seconds or so for folks to answer. Sounds good. I think we've got everybody in for the most part, so we can move forward on that.
Perfect. So the answer was all of the above, as we just saw on the previous slide. Executive functioning includes those, as well as a lot of other higher level thinking abilities. All right. We are going to move on now to insight and awareness. This is one of my personal favorite subject matters, because it has such an impact on just overall outcome, just the ability to engage in therapies, and just stress levels of family members and those sorts of things. So when I talk about insight and awareness, it's essentially impaired insight and awareness in challenges associated with the injury. And the individual oftentimes has a hard time being able to reflect on how these different changes are impacting their ability to function. And this is something that we commonly see, that kind of that lack of insight and awareness. And it can range from like where there's no like emotional connection, a true anosognosia, where you confront the individual like, hey, this, the left side of your arm is not working, or the left side of your body is not working, and they seem really indifferent about it. To those folks who, you get a reaction, you can get angry, that you might see some anger, denial, anxiety, a lot of different emotional reactions, but they're not linking what you're noticing or what you're trying to tell them about their injury and how that's impacting them. And they kind of go to, well, I'm fine, I can get back to driving, or I can get back to work. It won't be an issue. Whereas the team and the family often see a lot of concerning things that would prevent them from being successful in returning to those types of activities, or even being independent in the home. So as you can imagine, if the individual's not even recognizing things to work on, or things that are different about them after the injury, there's not a whole lot of motivation to work on them in therapy. So buy-in can be really, really hard. And then there's a sense of increased burden on the caregivers, family, support network, friends, to kind of help support, because it can almost feel like you're on two different worlds. And it can be, it's incredibly difficult. And so something that's, it's a team effort, absolutely, is kind of helping guide, especially on that inpatient side, of how to build some of that insight. But what I've noticed through my time here is that opportunity for being able to build insight happens most dramatically when folks transition to an outpatient setting, because they're out in the real world, there's less structure, and there's more opportunity for them to kind of experience supported failures, in a sense. All right. So let's go back to Mr. X here. So like I said, I did some testing with him about 9 weeks post his injury. He had emerged from PTA at that point. We had built some rapport, and he was willing to do some testing with me. His premorbid estimates put him in the average range. He did show some difficulty with basic attention and kind of that working memory. His processing speed was slowed, both with, a motor component and without. His memory, his verbal memory was a lot more impaired than his visual memory. Verbal memory did benefit from a kind of a recognition. So, hey, when I read you that story, or when I read you that list, was this word or that part of that. And he was definitely more accurate when given the opportunity for recognition. And his visual memory, although it was impaired, it was definitely better than his verbal memory. What he really struggled with was when so basically with the visual memory, it was drawing a complex figure. He got the gestalt of the figure, but what he really struggled with were the details. His executive functioning was variable. He had trouble with multitasking, incorporating feedback to correct himself. He wasn't able to self-monitor, difficulty with rule following, and he did show that he was able to actually talk through some pretty basic safety scenarios, which was good to see. He had incredibly poor insight into his physical challenges and his cognitive challenges, which made it really tough to get him to engage in therapies. And I'll talk a little bit later about how we kind of were able to integrate some of these findings in to kind of help build in a little bit of that buy-in. And essentially these findings were congruent with, you know, where his brain got hurt, the medications that he was on, and just the observations from the team members. So once the evaluation is complete, then it's important to provide that feedback of how someone did. At the core of a feedback session, it's an opportunity to explain in detail not only the assessment results, but also an opportunity to provide education and information about someone's injury and the impact that it's having on someone's everyday functioning. And as I mentioned earlier, that can be incredibly validating, even as early as inpatient, because families are a part of that, or the support network is a part of that feedback process. And so it's helpful for them to hear and sometimes feel validated in seeing that there is data that helps back up their experience. You know, in providing feedback, whether it's inpatient or outpatient, I think it's kind of trying to hit each of those points. But I think it's also a balance of being ready, recognizing that not everyone's ready to hear all of the information. It just depends on where they're at and how they've processed and where they are in their grieving process with this, level of insight, kind of, you know, where, yeah, it's kind of a dance in a sense of kind of trying to gauge where someone is at and their family members, and recognizing that even though they may not be ready to hear everything, that it's important to at least start planting some of those seeds in the hopes that as they get more time and more experience, that those seeds will grow into something, and they'll be able to reflect and take that information that maybe they weren't ready to hear in the moment, but later on reflect on it. I also think it's very important to kind of approach feedback in a therapeutic way, you know, creating a safe space, allowing space also for individuals to experience whatever emotion comes up as we're kind of going through the information. So that this kind of allows people to ask, you know, questions that might feel silly, but really they're not. It's important. You got to meet people where they're at, and make sure that they're getting everything out of it, because they've definitely worked really hard to engage in that evaluation. All right. Okay, Tracy, we're ready for the last poll question, please.
You got it. So I think my microphone's working now. Impaired insight into one's deficits following a brain injury has the potential to significantly impact family burden or awareness. And if those are true or false, is your question. And just as a side note, a few folks have asked if this is being recorded, and it is. So when we send you a follow-up email, it will have the link to the recording. So you can reference this at a later time. Got about 5 more seconds and we should be good to go. Okay.
Perfect.
think
So
we're
the answer
good,
to, okay, thank you. So the answer to that one was true. We just reviewed some of that information, and it's a particular area that I like to pay special close attention to, especially on the inpatient and outpatient side, and as you know, as we kind of have the opportunity to follow people, how that evolves and changes. And something that I get asked often is, is there a specific measure or tool that you use to kind of track that? And I personally don't have something that I use to like a particular measurement to assess level of insight. There are measures out there to kind of get a sense, where folks kind of have to self-report different things, and you can kind of gauge it. But I think it's more just being able to have that conversation and that collateral information from family members, team members, to kind of get a sense of where that level of insight and awareness is. All right. This is another tool that I really like to use. One, it kind of helps build a little more insight and awareness into thinking skills, because it's kind of in this nice visual format. But also it's helpful to kind of see how things are falling on a normal bell curve. And it kind of makes things feel a little bit more tangible when we talk about, when you talk about thinking skills, it's kind of meta. So this kind of helps it seem a little bit more tangible, mapping, the results to a bell curve. So in this example here, like I put in a line that kind of shows, all right, where is the estimated premorbid level of functioning? So everything above it would indicate kind of things that are within normal limits for that individual. Anything below would be a change for them. Like I said earlier, I mean, we all have natural strengths and weaknesses when it comes to our thinking abilities. So it's not necessarily trying to make sure that all thinking abilities are right there at the estimated premorbid level, but it's just kind of a helpful guide. And then below, I think just kind of mapping out the ranges, or kind of where those different cognitive domains fall, to kind of, again, help it feel a little bit more tangible when you're talking about results and going through that feedback process. All right. So kind of I think the meat of kind of what neuropsychology is able to provide, kind of to the holistic setting of treating folks with brain injury, is kind of that recommendations piece. Again, I kind of separated it between inpatient and outpatient. I mean, everyone's recommendations are going to be different, just because everyone's got different goals, different, strengths, different areas of challenge. But essentially, I mean, we're able to depending on the information that we gathered from the evaluation, we can address some of these types of recommendations. Level of supervision, whether that's with finances, medication, minors in the house, behavior management strategies. We can talk about recommendations if repeat testing is needed in the future, among some other things as well. And then kind of incorporating these findings into treatment planning. And I cannot emphasize enough that this is a collaborative process and that this can't be done without communication. And I think it's incredibly important to, when we're incorporating these findings, kind of thinking about someone as a whole. And like I mentioned earlier, I mean, each discipline is going to provide a different piece of that holistic viewpoint or picture of that person. I think really where neuropsychology can help is, how, now that we know where the strengths are from a thinking standpoint and also the areas of challenge, kind of like how that family works, kind of, are there mood things going on? Are there behavior challenges that are coming up? How can we utilize all of that information to help guide the team or kind of modify our resources to help this individual's best outcome? Let's see. I think also a valuable thing is, if there is impairments in awareness and insight, is how do we best partner with that individual in helping to achieve some progress. And sometimes it's just building that rapport. I never estimate that process, and starting with something that's motivating to them, to kind of build on that, to start working on some of those bigger goals. And then I think it's incredibly important, because to address some of those contributing factors like fatigue, sleep, substance use, identifying a new sense of meaning and purpose. That's really important in this process. Addressing any sort of psychosocial stressors. All right, move on to the next. So going back to Mr. X, so on inpatient, the main focus was just building buy-in, given his poor insight and awareness. I mean, he really he didn't think he needed the therapies. He didn't think he needed to be in a hospital. So kind of going back to that point of, I mean, our first block was building rapport with him. So that often meant not necessarily working on clear therapeutic goals, but just taking the time to show him that, we care and we want to build a working relationship. And once that was solidified, then it was easier to get him to engage in more traditional therapeutic therapies. And of course, adjusting those treatment goals as he continued to make improvements. Because his verbal memory was much weaker than his visual, making sure that we were tailoring, if we needed him to remember certain steps or, different protocols or new information, that we were presenting it in a way that he could learn at his best based on what the testing showed. Providing a lot of emotional support and education with his family. And then utilizing medications to address his irritability, poor attention, as well as implementing some of our behavior management strategies. And a lot of them were geared towards creating a low stim environment, just kind of monitoring and watching, making sure that we're coming in with the best possible intentions into his room, and really showing him verbally and non-verbally that we want to help. Let's see. Then I was lucky enough that I was able to follow him into our outpatient program, and I was able to do some repeat testing at 6 months post-injury. He showed really cool improvements in his attention, processing speed, and visual memory. He continued to have pretty significant difficulty with his verbal memory and executive functioning. So again, he struggled with solving new problems, kind of that flexible thinking, perspective taking. That continued to be pretty tough. The cool thing was that when he transitioned to the outpatient program, he did start having some increased insight into his cognitive and physical challenges. So it made it a lot easier for our outpatient team to get him to engage in a lot more therapeutic tasks that challenged him. The one thing that he still struggled with was kind of that insight into his substance use and mood. And once I got the testing out of the way, I was really able to focus on kind of helping bridge that a little bit more. And when he was ready to transition out of our outpatient program, he was willing to go to AA meetings and transition to a community and the provider, which I provided a warm handoff and provided just continued support and education with his family while he was part of that outpatient program. Another valuable tool that neuropsychology can provide is just monitoring cognition. Oftentimes we'll recommend repeat testing 3 or 6 months post-injury, and sometimes even testing at 1 year. And then testing beyond that, I mean, happens if there's a significant improvement or a significant decline, especially when there's a change in medical status. The value of the repeat testing is just tracking cognition over time, mood over time, and it allows us an opportunity to update treatment recommendations and guide community reintegration. And I put in at the bottom there, so a lot of our standardized tests, you know, we don't get to allow someone to use all of their compensations and tools that might help with, like, let's say verbal memory, or some of the executive functioning. And so that, again, that collateral information of how someone is functioning with their tools and incorporating that in with the data that you've collected in the testing. You know, I was recently reading some articles about some just outcome research with those after brain injury. Again, that's probably a whole nother talk, but I do want to plant the idea out there. I mean, you know, functional improvements can occur well beyond that first year post-injury. There's literature out there that shows individuals several years, decades after an injury who participate in a comprehensive, holistic rehab program, whether it's inpatient, outpatient, show improvements, which is pretty darn cool, I think. So that kind of testing that neuropsychology can provide can be helpful throughout all of that. All right. So going back to Mr. X, like I mentioned, we did some repeat testing at 6 months post-injury, and that information, you know, the improvements in attention, processing speed, visual memory, I mean, that was helpful in guiding his, you know, return to driving, work, school, and that information was in conjunction with the assessments that he completed with occupational therapy, physical therapy, and speech therapy. And with Mr. X, so at about 18 months post his TBI, he experienced an unexpected seizure that led to a ground level fall and unfortunately a brain bleed. So he kind of came back to us with like a different presentation after this brain bleed. And I was able to complete some limited testing with him. But with his new challenges of difficulty with reading, he had a visual field cut, he had challenges with his visuospatial ability. So they came in with an example of he had a difficult time seeing and understanding like where things were in the fridge, for example, like where's the butter, where are the carrots and those sorts of, he couldn't quite navigate through that. As well as expressive aphasia. So his comprehension was intact, but he wasn't picking the right words to express himself. And interestingly, with this new injury, his insight and awareness was not impacted this time around. So with that came a lot of heavy emotions for Mr. X, a lot of anger, a lot of sadness. I think a lot of it was just kind of big why questions. And that was something that I was able to kind of work with him on. And eventually, when he was feeling confident with his language abilities, transitioned him to his provider in the community. So in sum, these evaluations can provide a lot of helpful information. It can be used in a lot of different ways. And it's an opportunity to holistically appreciate someone's strengths and challenges following an acquired brain injury. And just wanted to thank everyone for their attention. I know that we're a little bit short on time for questions, but we'll get through what we can, and please email. I'm happy to answer questions through email as well, especially the ones that we didn't get to, or if something comes to you later on.
That's great, Bibi. Do you mind going to the next slide just so everybody has
sure.
our emails and stuff?
Yeah.
And again, I apologize for the audio that I had at the beginning. Just as a follow-up with everyone, thank you so much for joining us. Credit is being provided from CEU Institute, so you will be receiving an email directly from them regarding your CE credits. So definitely keep an eye out for that. Sometimes it can hop into your junk folder. And then you'll also receive a second email from us, from Craig Hospital, and that's a separate survey, and we really would appreciate your feedback because that gives us, helps us out with any future interest of what you guys are looking for to hear from our amazing Craig staff. I do have two, I can combine two of the questions if you have a moment for that, Bibi.
Yeah, of course.
So this one's kind of a two-part, I think we can roll in, but how often should a neuropsych eval be repeated?
Mm-hmm.
And then if that needs to be repeated years after the first one, is it important to have the same person do the evaluation? And what if that provider's not available?
Yeah, so it's kind of a balancing act on how often these sorts of tests should be repeated, just because of practice effects can impact the validity of the information or the validity of the evaluation. So, I mean, when we've got folks that are functioning cognitively at a higher level, spacing it out maybe like 3 or 6 months is more beneficial so that you're not getting those practice effects versus, let's say, someone where you're just trying to get some basic like attention processing speed, language function. You can probably do that a little bit more frequently. And then that's a really great question about, let's say someone needs an evaluation years out. I don't think it has to be with the same person. I think any neuropsychologist could pick up that, the prior, report, or even start a little bit from scratch and kind of get some of that background information. I mean, having access to that previous report would be helpful just to have a comparison, but definitely not hard. Yeah, I think it would be okay to meet with somebody else.
Great. And I don't know if we might have time for
I think
one
we
quick
just
one.
lost. Oh, okay, sure.
We might, I don't know, we'll see. A patient has passed all their physical examinations. They've demonstrated their ability to do their job physically, but coworkers have noticed a change in response time. Of note, he's a first responder, so there's concern with that change in response time. So would neuropsychological testing be appropriate for an
Yeah,
individual?
absolutely. Yeah, I think that would be helpful to get a little bit more information about where the breakdown is happening and why. Is it truly a processing speed issue, or is there something else going on contributing to it?
And I know this is, I know we should probably be done. So what I can do is there's, I think, 1 or 2 other questions out there. I will send these to Dr. Stang and she can answer those and we will supply those answers to you at no charge. We'll send those emails back out to you. Thank you very much for joining us. We really appreciate your time today. If you do have any questions, feel free to reach out to Dr. Stang or myself. And we are looking at having our next webinar in June. So thank you again for your participation. Have a great day.
Thank you.